All right, it's my pleasure to introduce Nikki Boye. She's currently completing a postdoctoral fellowship at the hospital at University of Chicago, and is a current trainee in the Health Services Research Program, an AHRQ T32 program. She joined the Center for Health and the Social Sciences, the CHESS program, in May 2018. And prior to joining CHESS, she held a position as a research assistant at the Health Economics and Health Technology Assessment Group at the University of Glasgow, which is where she also completed her PhD. She's currently working on economic evaluations in a variety of public health and community interventions, which I think is what she's presenting today, right? Some of that, okay. And then she's also doing work with David Meltzer, right, in the economic evaluation of the comprehensive care physician program to improve doctor-patient relationships, coordination of care and reduce hospitalizations. And she is working with us here on 2 ICER reports that we're doing right now. Nikki's research interests are both methodological and applied and include economic evaluation alongside randomized controlled trials. She has methodologic interest in decision analytics modeling, econometrics, quasi-experimental and natural experimental design. And her areas of research interest include public health, child health, mental health, outcomes, pediatric quality of life, social determinants of health, health inequalities, obesity prevention, and cognitive decline. So Nikki is interested in everything, and she does fantastic work. I'm really pleased to introduce her. So Nikki, welcome.
Thank you. All right, thank you very much, Dan, and thank you all for inviting me to be here today, as well as coming to the seminar. Basically, can everyone hear me okay? I know it's no. I'll try and project as much as I can.
Yeah, that's the light.
Right.
If you don't mind, just please turn off the audio.
Okay.
Hope everyone online can hear.
Yeah, that mic will pick you up.
It'll pick you up anywhere. Yeah, you're
Okay.
close enough.
All right. Is that better?
Yeah, that's right.
Okay. Yeah, so I'm Nikki Boye. I recently moved back from the United Kingdom where I was completing my training in health economics. So today I thought I would just use the time to give you a little bit of background into my experiences over there and give you a little insight into the British healthcare context in terms of healthcare decision making and economic evaluation. So my background, as we mentioned in the pilot or the introduction, is in public health. And so I actually completed my bachelor's at U of I here in Champaign. I majored in community health, my master's in public health, and my PhD in health economics was at the University of Glasgow in Scotland. And this is, okay, now it's working. The first picture here is the main building, University of Glasgow, and these are the cloisters. So it was very lovely and gothic, and I always thought kind of Harry Potter-esque. And so I really enjoyed my time. There's a lot of history to see there. This, incidentally, is the Glenfinnan Viaduct, which is also known as the Harry Potter Bridge that they take when they're driving to Hogwarts. That's a few hours north of Glasgow, but yeah, it was great. I was at the Health Economics and Health Technology Assessment Group that was started by Annie Briggs in 2006. That's just a bit of background. And then apologies if this is a bit elementary. I wasn't really sure what everyone's familiarity would be with HTA. It's a couple of definition slides here. health technology assessment. That's the systematic evaluation of the properties and effects of a health technology, addressing the direct and intended effects as well as unintended consequences, mainly aimed at informing decision-making regarding health technology. So a health technology can be anything such as an actual technology like an MRI, or it can be a drug, a therapy, it could be a new surgical intervention. It's anything that you do to improve someone's health. So then the next thing you have to define is economic evaluation, and that's the comparative analysis of alternative courses of action, both in terms of their costs and their consequences. And that comes from the Blue Book, which is right here. Pretty much the Bible for economic evaluation and the different types of economic evaluation, how to carry it out. So I'm mainly going to be focusing on one type, and that's cost effectiveness analysis, or in the UK it's typically referred to as cost utility analysis, which just refers to the fact that you're using a cost per quality outcome, or quality adjusted life year. So yeah, main goal of economic evaluation is to maximize health benefit within a given budget restraint. So to give you a bit of context, in the UK they have the National Health Service. It's a single-payer healthcare system. The government runs and funds all of the NHS, and it's celebrating its 70th anniversary. It was set up in 1948 under the premise that good healthcare should be available to all with access based on clinical need, not the ability to pay. And so it's free at the point of use. It's funded entirely by the national insurance tax that gets taken out of paychecks, right? So you never actually even see it. It's kind of like FICA, it's a larger percentage, obviously, because it funds the whole healthcare system. So just the system is set up, you have a GP, which is a general practitioner, and they act as a gatekeeper to specialist services. So I guess that's one kind of major difference, in that it potentially kind of contains some costs in that you kind of have to flow through the system a certain way. Direct-to-consumer advertising isn't allowed, so you would never have someone coming to their GP and asking for a particular drug, because the advertising about it is just not allowed, so they wouldn't necessarily know about it. And then I think there's a difference in the attitude towards healthcare professionals. Generally, I think there's a lot more trust placed in doctors. There's hardly any malpractice suits. I mean, things like accidents happen and there are lawsuits, but it's not nearly to the same degree as it is here. And I think people as well are very proud of their NHS. They have private health insurance, but they're wary of it becoming a two-tiered system where private health insurance takes up too much away from NHS. So even though people can afford private health insurance, they generally tend to use the NHS. So these are just kind of some context to set you up. I know I've been to a lot of seminars where people compare the U.S. to, for some reason, they love to choose the UK as the European country to compare in terms of healthcare reform. But there are some really important, cultural differences, and really, I think it comes down to values in terms of how you want your healthcare system, what you want to get out of your healthcare system, and that's important to keep in mind when people are comparing it. It's not so simple as that, I guess, is what I'm trying to say there. Okay, so this is not an extensive or comprehensive list of pros and cons between NHS and our health system here. It's just basically an anecdotal account from my experience using both health systems as well as being a researcher in both places. So we'll start with the pluses. It's free at the point of use, which is obviously great. It's easier to navigate. You never have to really worry about how much it's going to cost to go get your medical problem taken care of. There's no surprise bills. Overall, they have a lower total health expenditure, and I'm sure you've all seen something similar, figure like this. I don't know if I have a, I don't think I have a, okay. So basically, here's the U.S. over on the end. They're the outlier with, this is health expenditure as a share of GDP, and it's around 17% for the U.S. You compare that to the U.K., it's just under 10%. So it's a sizable difference. And quality, it's not like we're getting so much more quality for that extra percentage that we're paying. It's like UK does better on like overall health outcomes. It depends on what your, I guess like life expectancy is the easiest, but that's, your health system doesn't necessarily impact how long you live. That's a lot more cultural, and we won't get into that now, but for the most part, quality isn't going to be that different. There's a safety net in place when you don't have to, the ability to pay is taken out of your care. And then there's also more standardization in the care that they give, so that equals less variability in the quality of care. And I think, like compared to the U.S., you're gonna see a huge variability in care and outcomes. Whereas because this is a kind of a single system, like everyone follows the same guidance. And I'll get into that later when I talk about NICE. But so yeah, because there's really costs are not a part of the equation day to day. There's more of a focus on outcomes. So I mean, obviously it costs money, but it's not a part of like a doctor's day-to-day. They can focus on just being a doctor and giving care. They don't have to charge or worry about billing or spend any of their time dealing with any of that. So I think that focus on outcomes is a lot better or higher. And then some of the cons of this type of system, you're going to have longer waits for non-urgent care. So for example, if you need an MRI and it's non-urgent for diagnosis, MRIs are fairly expensive in terms of what you get out of it. So they just have fewer machines, and you might wait up to 3 months just to get, or a few months just to get an MRI for a non-urgent diagnosis. Whereas you get it right away. You do pay for it, but some of their facilities are going to be older and less modern. It's 70 years old, and a lot of the hospitals were set up 70 years ago when NHS was created. So you've got older historic buildings, and they're not necessarily fit for modern day like healthcare, but it obviously still works. It's not like their quality is less. Then you have the way it's set up. You'll have wards versus private rooms. Here, private rooms are relatively unheard of, at least for when you're recovering. When you recover, you're always in a ward with a bunch of people, and the nurses there would say that they prefer that because they can keep their eye on everyone. But private rooms might have the benefit of maybe preventing less hospital-acquired infections. So that's kind of like a matter of preference, I think. My husband as well, he always says, like, when he ended up in hospital, like, recovering in the ward, he thought he would be so lonely in a private room just because there's nothing to do when you're recovering, and at least you have people to chat to. So it's a matter of, like, a kind of cultural difference, I think. So certain drugs and therapies, technologies, they're not going to be available in the UK because as a way to, like, keep costs down, the UK, like, they have more bargaining power in that there's just one negotiator, basically, and if they don't like the price, they simply can walk away, and they have walked away. So certain drugs and therapies that they deemed were not cost effective are not available in the UK. And so another less talked about kind of con is that inequalities in health still remain there. even when the access is universal. So they don't even have like race as a contributor to inequalities. I mean, everyone's majority white, but the fact that these inequalities still remain, it just points to it's mainly socioeconomic status and the indicators for that. But they are still dealing with the same sort of issues that we have here. And then also, this final one is like a plus or minus, however you want to look at it. There's less choice as a consumer of health. You go see your GP and they kind of dictate your care. And depending on how you look at that, me personally, I kind of prefer that because it's easier. I don't want to have. I trust the medical professional to know what's probably best for me. Like, I don't want to have to do my own research and and contribute to that sort of my own treatment plan or whatever. But obviously that's a very different kind of a cultural thing as well, I think, to think about. So, oh, by the way, I don't know how formal, but if you guys have any questions at any point, feel free to interrupt me. So this is just a map of the countries of the UK. So NHS is uniform. However, each country operates independently, their own NHS, if you will. So in Scotland, it's NHS Scotland, and Northern Ireland is the Health and Social Care. In Wales, I don't know how they say that in Welsh. NHS Wales, and then finally in NHS England. So whatever you hear about the NHS, you're usually hearing guidance or stuff from NHS England because it's the biggest. And the rest of the countries are referred to as these devolved administrations. So they generally follow everything from England, but they can decide exactly how they want to deliver the service. So at least like small, slight differences. One example is in NHS England, they have a prescription charge. I think it's around £8 or something, whereas I'm almost certain every other country doesn't have a prescription charge. I know at least Scotland doesn't, for sure. So the NICE, the National Institute for Health and Care Excellence, this is what I was kind of referring to earlier in terms of like standardization in care. They issue evidence-based guidance and advice to improve health and social care. So there's the NHS, which is health. There's also personal social services, which is like social care. And basically, it was implemented in '99, I think, to end what they called the postcode lottery. So basically, it means wherever you live depended on the type of quality of care you would get. So certain postcodes were rationing care a lot more than was necessary, and that impacted the outcomes. So this guidance was meant to standardize care for all of the NHS. But NICE guidance is actually only for England officially, but the other devolved administrations can usually take the guidance and implement it as is, but they can decide if they want to change it at all. And so, because I was based in Scotland, I didn't actually ever attend any of the NICE committee meetings. Those were in London. Scotland has their own sort of smaller version of NICE. It's the Scottish Medicine Consortium, or the SMC. And it's set up, I went to one of the committee meetings. It's set up very similar to the ICER meetings here. Has anyone been to any of the ICER meetings? Yeah. Well, I definitely recommend going. Members of the public can attend, and it's really interesting to see how they're kind of set up. So the main difference, I would say, between the SMC and ICER meetings is at the end of an SMC meeting, so basically I'll describe it a bit. You have all these different stakeholders discussing new drugs or technology, and so there's the patients, there's the doctors, there's the health economists, there's manufacturer and advocacy groups. They all get their time to have their their input, and then at the end they vote on whether or not they think the new drug is cost effective. So with SMC, it's a yes or no, is it cost effective? And with ICER, it's kind of like, is it likely to be cost effective? And there's a few more questions that they vote on. So with SMC and NICE, this yes or no decision has a bigger impact because it basically determines if that drug is going to be available under the NHS. Here, the drug's still going to be available if you're willing to pay for it, so less of a impact, if you will. And I would say as well, I think SMC meetings were slightly more formal, and that the chair is very strict about everyone got their equal time to give their input. As a member of the audience or public audience member, you couldn't say anything because the thinking was that it could be like the manufacturer sending people to act as members of the audience, and they might be vocal, and then that might influence the committee's vote. So it was very formal in that sense. But yeah, so similar to ICER, I would say, definitely encourage people to go attend the meeting. And so health technology assessment, this is what they're discussing, like, at these meetings. They use a reference case, which I'll show you here. It's basically guides the development of all economic evaluations, how they should be set up to promote standardization in the methods used, so that basically committee members they know that it's been formed the way that similar way as before, and they can reference like previous decisions to make sure that they're comparing like with like. So they specify that you should use a cost utility analysis with a fully incremental analysis. So incremental is the additional benefit over the additional cost of the new drug. And so, I just want to make the distinction. I don't know if I did it earlier, but in the UK they call it a cost utility analysis, and that just means it's using a QALY, but here it's generally referred to as cost effectiveness analysis. There is no distinction between what outcomes you're using. And then I'm not going to go over every bit of the reference case, but health effects should be expressed as QALYs, and then they should use the EQ5D to do that. And this is the EQ5D. This is just the 3 levels version. So there are 5 dimensions and 3 levels in each dimension, and it's a very generic overall snapshot of your overall quality of life. It's not, if your drug or intervention only impacts on one domain, it's not going to show a huge change. So it's not the disease-specific outcome measure, and clinicians always have an issue with how it's not very sensitive. But that's the whole point, so that you can compare apples to apples, different drugs, different interventions. If you have any more questions, just silence, please. Working on the 5L version for U.S. sites. Really
Just
cool.
got accepted, yes.
Nice.
So,
Good job.
I'll send you the algorithm right away.
Yep, perfect. And then equity consideration. Okay, so this goes along with the threshold. So they actually do state threshold that they consider cost effective. So it's generally 20 to 30,000 pounds per QALY. But these equity considerations, it means that additional QALY has the same weight regardless of the people who are going to get them. So it's a QALY is a QALY is a QALY. But interesting, they have this end of life criteria that they now, which is a bit controversial because it goes against these equity considerations. So if your drug extends life at the end of your life, it's worth more. So you're allowed to spend 50,000 pounds per QALY if it meets the end of life criteria. And that's really controversial, and it's basically there just to get some of the very expensive cancer drugs into the NHS. But so these are, you can see how decisions by NICE are going to be very controversial because they're basically placing a value on life. They're saying 1 year in perfect health is worth 20 to 30,000 pounds. So some of the headlines that you might see whenever they make a controversial decision is usually to do with expensive cancer drugs. Yeah.
So you said that at SMC they actually like vote on the cost effectiveness of it. So if they're given like a threshold and then the results of like that model or whatever, what are they actually voting on? Because if it's under, then they would vote yes, right?
Pretty much, yeah.
Okay.
So I mean, the decision's pretty much, the evaluation is given to everyone beforehand. They have time to review it beforehand. The discussion is there just to kind of put any more like outside input that they might not have seen from the evaluation. But most people have already kind of made their decision based on the results that they were presented. So this slide kind of explains how you could work on economic evaluations that are outside drug evaluations in the UK. So typically you hear about HTA and it's just for the drugs mainly, but I didn't actually ever work on any HTAs because my interest is in public health. So I worked on economic evaluation of community health, public health type interventions that happened outside of the hospital setting. And basically the reason I could do that is because of this National Institute for Health Research, the NIHR. It was set up in 2006 under the government's health research strategy, and it basically integrated all the research system and funds. So you kind of have one main funder that everyone is competing with, so that kind of makes it so that maybe only the highest quality research will get funded. There are smaller grant funding bodies, but most of the research that gets funded is from NIHR, and most of my projects that I worked on over there were NIHR funded as well. So it's the largest one in the UK, and it works closely with the devolved administration. So usually the calls go out, it's for NHS England, but anyone from the UK can apply to them, which is why I was on a bunch of NIHR grants as well. So basically, anytime you want to do a randomized controlled trial, you're not going to get funded unless you have an economics component. And so that created a lot of work for health economists, and it's basically how, like, there's a lot of work, methods work coming out of the UK, and it's because they're willing to pay for it. They are investing highly in health economics research. So it basically connects universities, NHS, local government, all of their funders to shape policy, strengthen the healthcare system, drive economic growth, and advance science, which ultimately improves people's lives. So not every university is going to have a health economics department. Mine didn't, and that's why one of my main PhD project that I worked on was actually with colleagues from Queen's University in Belfast. So basically that's how there's a lot of work, because if you don't have a health economics department, if you don't have suitable economic CI on the grant, you need to go outside to resource or to do that, basically. So it's not the same here, so I guess it's a little bit, my position's a little bit more precarious. But so this is, I thought I would just end with some of the programs that I worked on while I was in the UK. So this first one, football fans in training. Football is soccer. It was a randomized controlled trial for men who were overweight. It was a healthy eating and weight loss intervention delivered to like middle-aged men who were fans of the local soccer team. And it was actually really cool. This was the first project I ever worked on, and they actually got to like train on the pitch of their club that they had been admiring and watching their whole lives. So it actually worked. It took off like crazy. It kept getting, like, it was my first project. I thought, I was only hired for 6 months to complete this project, and I thought I'd be done with it, but I ended up working on it my entire time I was in Glasgow because it kept getting, like, follow-ups funded, and they even, it was originally Scotland, and then they did it in the rest of the UK, and they've even got a Eurofit now where they're piloting the program in different countries in Europe. So then the other one, as I've been mentioning, my main project I worked on for my PhD was a cluster randomized controlled trial evaluation and cost-effectiveness analysis of the Roots of Empathy program. That's aimed to improve social emotional well-being in children at school. So that was completely out of like kind of what you consider health technology. It was in the school, and it was the health outcome was social emotional well-being. So it was kind of a cool way to kind of apply the methods in a really kind of foreign setting, if you will. So there is a lot that you can do. It's not just the drugs that you have to work on. Obviously, you guys are all interested in the drugs, but I just thought I would kind of give an insight into how you can apply those methods outside as well.
Did you do an economic evaluation of the first project?
No, so I just sit on the model for the long-term.
Because I could imagine that may not be a very cost-effective intervention if you consider the salaries of the football players that are involved in.
It's not the actual football players.
Okay.
It's like some of the coaches and some of the like.
So they're not engaged at all in part of the process.
The players,
Yeah.
no.
Okay.
But the draw is just being able to like be on the pitch
Yeah.
and with like and actually getting back in shape enough to be able to play football again. And so that's what I think it was. And they managed to keep it off because the idea was it's only a 12-week intervention. But the idea is you start to form relationships with the other participants and you keep playing afterwards. So after a year, people did manage to keep 5 pounds off. So,
You may have mentioned this, but when there are non-drug health technologies, how is the decision around implementing those health technologies made in the UK?
right. So that's a little bit hairier, if you will. So basically, we do perform the economic evaluation, but it's really just an aid to the decision makers. You don't have to like one component, and it doesn't always impact the decision of whether or not they're going to implement it. And unfortunately, I haven't been around long enough to follow up what's happened, but but it's just mainly contributing to the literature, and if it does impact policy, like that's a huge deal, but it's not as big of a yes no decision.
Other questions for Nick?
Did you do that study at Wrigley? Baseball, but I don't know baseball. Can you just? You have to have running the bases. But, yeah. Cheers. Right in the, yeah.
Nikki, what's the relationship between the NIHR and Medical Research Council?
They're like separate. So NICE is for England and MRC is for Scotland. So it's like a smaller version of NICE for Scotland, and it's just for drugs, not for health technology in general. So for the drugs and it's in Scotland, they go to MRC if the NICE advice is not being implemented.
Can you speak to the role of the decision support unit in NICE, and is there an equivalent for ICER?
I don't know. I'm not sure that I can.
So what does decision support unit do at NICE? Are you familiar with that?
No, I'm assuming they're made up of the health process, and similar to.
So it's responsible for the concept adopted for any kind of major decision in the NHS, National Health System. By law, they're required to validate the model,
Right, okay.
and so the decision support unit would be responsible for overseeing or coordinating or conducting that.
They do that with they do it at it.
Right, and it just as an aside from the perspective, you mentioned the EP5D. I imagine we didn't do that just for my sake, right? Like that's
No.
actually
Yeah.
a major kind of part of their decision making, right?
Yeah.
So this transition, kind of good timing that you're here because I presented on the 5-level evaluation study just 3 weeks ago, right? And the transition from the 3 level to the 5 level.
It's gonna ruin things, yeah.
Well, it's going to change. Yes, it's ruining things, right? Yeah. It changes the threshold for, and you showed those newspaper headlines. Now they're going to have to change the threshold depending on the size of the Oxford quality that would otherwise be estimated using the 3-level system, now it's a 5-level system.
Yes.
And this business decision support unit has a role in terms of ensuring that the modeling and that the use for the 5-level system was appropriate, data is appropriate, how it's modeled, which is one reason why it's taken us 14 months to get all our modeling very straight to the U.S. I don't think we have a parallel kind of check and balance from the perspective of how models are kind of vetted and validated. But the UK being a leader in methodology because they invest in economic evaluation has helped to establish that kind of benchmark. And that's kind of secondary benefits of having this kind of system in the UK.
Questions for you. The first is about the end of life special case. You mentioned that they have different thresholds for those.
Yes.
I remember reading like a few years ago, maybe that's not anymore, that they also in the models have the health gain to perfect health for those. Like they consider that those patients would achieve perfect health during the lifespan that they live for. Do you think that that's still the case, or?
I'm not aware of that, but it might just be that I'm not familiar. No, it's the same criteria. It's just that you have a higher threshold if you can meet the end of life criteria set out.
My second question is about lawsuits. I used to work in a PhD agency in the country that had single payer healthcare, and we had a lot of problems with legal action against the healthcare system to achieve, to have access to drugs.
Right.
So much so that right now we have PhD agencies in the judicial system to support this.
Oh, wow.
So is that a problem?
I can't speak to that actually because I just didn't hear about it as much. And I'm in terms of like I wasn't in England. I was nice and so the main one that here, but I was in Scotland, so not like just from my experience, I wouldn't think so, but that's not my area, so couldn't be certain.
My next question is about the billing and reimbursement. You mentioned that in this scheme, doctors don't have to spend too much time working in the billing.
Yes.
So I assume that you're implying that all hospitals have this kind of budget instead of receiving reimbursement for service.
Yeah. So they have a budget, but like it's not. When we do economic evaluation, we like apply a unit cost. Like it's not an actual cost that has been billed. They get a certain budget, and that's how and they use it to do the service. And nothing is like, costed out as this is how much you get for doing this. But they have unit costs that they apply, taking into account. Like it's more reflective of the actual cost of delivering it because it takes into account the time and then the resources they use. But that's not actually what gets like reimbursed, if you will.
More questions, Andrea? You hit your quota.